And
Yeah. Okay.
Martha, would you just say a little about yourself too, since
Sure.
I didn't do a good introduction there? Thank you.
Yeah, my name is Martha Seabury. I've been working at the Maine Health Center for Tobacco Independence for about 18 years, and I've done intensive tobacco treatment in a variety of settings. So I worked on our telephonic state quit line, which is now known as the Maine Quit Link, and worked in some face-to-face outpatient clinics, at the bedside up at Maine Medical Center. Um, I facilitate tobacco conversations in IMAT groups, rotate through those. So I'm really glad to be here today. I will disclose that I'm not a specialist in pregnancy, but hopefully I can share some things that will be helpful for you in this brief time together. Um, so I don't have anything to disclose. These were my objectives, and that's my time frame. So I'm just going to break it down, like Lisa just shared. Um, and so, according to the Smoking Cessation Leadership Center at University of California, San Francisco, smoking is a risk factor for non-medical use of prescription opioids. They say about 85% of patients in treatment for opioid addiction smoke. I would say working with this population, you might find it even higher. Mothers of babies reported as drug affected were 6 times more likely to smoke during their pregnancy as other mothers. But this is what we know. When people continue to use nicotine when they're in treatment for other substances, they're more likely to relapse to that substance. Smoking abstinence does not lead to an increase of use of the other substance, and treating them concurrently has improved outcomes. We always give people a choice. Not everybody wants to do that, but we like to share with people. It often works better when people quit substances together. So this is a really crowded slide, and that's because nicotine and tobacco smoke are known to cause harm to mom, developing fetus, and the baby. There are over 7,000 chemicals in tobacco smoke, and 70 of them are known carcinogens. So the constituents of the tobacco smoke, including nicotine, will easily cross that placental barrier, reducing oxygen and nutrient delivery to the fetus, can reduce fetal growth, increase risk of preterm delivery, as well as incidence of still birth. So for the mom, she can have increased bleeding during pregnancy, premature separation of the placenta. The placenta can end up covering the opening of the cervix. She can have premature breaking of her water. She can also have decreased thyroid function, and that can lead to preeclampsia, premature labor, fetal death, or low birth weight, intellectual impairment for the baby. For the baby, the risks are low birth weight, increased risk of birth defects, including cleft lip, palate, or both, damaging to developing lungs and brain, developmental delays, problems with hearing and sight, and increased risk of SIDS. And I just want to quickly mention that pregnant women exposed to secondhand smoke have increased risk of miscarriage, early delivery, low birth weight, and SIDS. And third-hand smoke is the leftover toxic particulate that persists on surfaces, so clothing, hair, furniture, after the burning tobacco is extinguished. Over time, that residue changes its chemical structure, so it mixes with the air and off gases, so it continues to put this toxic substance out into the environment. And for pregnant women, these toxins can transfer to the fetus, impacting lung development. So that's just what it looks like if posters or pictures are taken down. It doesn't respond well to normal cleaning. It can last for months after a smoker has left the environment. So I just know there's so many things that you're trying to address every time that you meet with your client or patient. But we also know tobacco use is harmful. So I'm going to just try to show you the least effort on your end and the biggest impact for your patients. Um, I just want to say it's not your responsibility to get somebody to quit, to get the woman to quit. And in fact, we can't make anybody quit. So to try to think of a successful interaction with your patient as making the conversation safe around tobacco so that they're willing to engage in it, and maybe be willing to come back to you for help when they're ready. This population in particular is coping with a lot of shame and guilt. And burden of social stigma. So, and I know that you can attest to that with the work that you do. So, I would say that providers have told us that they don't have time to address tobacco, or sometimes they don't know what to say. Or if they address it, it doesn't seem to matter because their patients don't quit and that their patients don't want to hear about it either. What's really interesting is the truth is even though they won't act happy when you bring it up, there's increased satisfaction with the provider when it's addressed. And it increases quit attempts and it increases quit success because the more times people try to quit, the closer they are to getting there. So, and we also know that if it's not brought up, it can be interpreted by the patient that maybe it's not important to you, or important to you that they quit. Maybe they're not important to you, or maybe you've given up on them. You used to bring it up, you're not bringing it up anymore. So maybe you just are thinking they can't do it. So the US public guidelines for treating tobacco use and dependence, that's the reference for our tobacco treatment since 2008. That link on the bottom, it's no longer in print, but it can be downloaded there. And it defines a brief intervention as one encounter lasting between 3 and 10 minutes. And this was designed to be able to be easily delivered in the primary care setting. This is what I'm chatting with you about doing. And so this framework is from the Public Health Service Guidelines. It's something that you can do quickly and begin doing right away. It's a 3-part message. So you're asking about their tobacco use because you care about them and the health of their baby. You're advising, and by advising, I don't mean you're saying you have to quit, but you're saying it's important. It's important that we do something about your tobacco use. And then referring them to the main quit link. The reason why I'm sort of addressing it this way is that to learn intensive treatment can take a while. It takes a while to do and it takes a while to learn. So you can easily just begin referring them to folks that know how to do this right now. And then if you want to learn more about it as you go along, we have lots of trainings on this. I will say that often patients will say no thank you or no, I'm not interested, but you've already done something important. You've been compassionate. You've let them know that you're there and you want to help when they're ready. And we're trying to just have across the board providers giving this consistent message because over time it will add up and make a difference to patients. So close-ended questions. Do you want to quit? No. We know many more people want to quit than would say yes to this question because there's a lot of fear involved and a lot of ambivalence. Fear around not being able to do it, fear around discomfort, stress, how to deal with their life without it. So we encourage just trying an open-ended question instead. How do you feel about your smoking? Or how do you feel about quitting? Often people, well, they might say, I feel fine about it. A lot of times people will say, I know I should quit, but, and then depending on what they say, you can kind of address that. So it might be, but I've tried so many times, I haven't been able to do it. So you could say, that's normal to have a lot of attempts. And we actually know the more you try, the closer you are to getting there. So don't give up on that. Or, I was so uncomfortable last time I quit. And so we could talk about possible use of medications. So it gives you a little bit more information about how they feel about it. And I do want to say that ambivalence is completely normal. Even for folks who are ready to make a quit attempt, they have some ambivalence. It's that mixed, I kind of want to quit, but I don't. And it's normal and it's good to tell people that it's normal. You kind of like it and you kind of know you should quit too, and that's normal. It's human nature when we feel pressured by somebody to do something that we push back, even if it's the very thing we want to do. So ambivalence is an abundance of feeling for both sides. Like I know I should quit, but I like it, or I'm not ready to. And so if we push as the provider, if we push, like you really have to quit, they meaning anybody that we're doing this with, will fight for the opposite. So if we're pushing for change, they'll fight to stay the same. But if we act curious, tell me more about it, tell me what you like about it, tell me your concerns, or could I share some information, asking permission to share information. What happens is, if we acknowledge their struggle in it and that their choice in it, then they are more likely to fight for the change. So it's just really interesting when you see it happening. If you kind of push for it, they'll push back. If you sort of back away from it, they'll come forward to you. And so it's what we say and how we say it. So we found it helpful to say, for providers saying something like this, I understand what you're saying. I like all my patients who use tobacco to connect with the Maine Quit link. Can I put through a referral for you? Um, and they might say no, or they might say yes. We definitely don't want referrals for folks who have not said no or you haven't discussed it with, but you can say these kinds of things. You don't have to be ready to quit to chat with them. They won't pressure you to quit. You can opt out at any time. You can do just one call with them and find out what it's about. You don't even need to talk with them. You can just connect online. So this is a wordy definition, but it's relatively brief as we've expanded our services. So if somebody calls up and says, "Who are you? What do you do?" This is kind of our answer. We're a free service for folks in Maine looking for help with quitting. We can answer questions, offer coaching over the phone, help you plan for your quit attempt, and offer you support. We also provide free nicotine patches, gum, and lozenges if appropriate. You don't have to be ready to quit to talk to us, and we offer online services if you're not interested in talking. Are you interested in enrolling? So I wanted to write that up for you so you might have that if you wanted to refer to that as some sort of explanation. So why offer referral to us? Patients are 10 times more likely to engage in treatment if you refer them to us versus giving them our number. The majority of people, if they make a quit attempt, 95% will quit cold turkey. That's without any support, medications, any kind of quit plan. I don't have specific data for pregnant women involved in the Maine Quit link, but for general population, those who continue with us through our calls and our medications, it's over 40%. So it's way better than 3. And we know that medication can double success rates, and I'm going to talk a little bit more about meds in a bit. And the most effective treatment, the evidence-based recommendations, is medication plus behavioral support, and the Maine Quit link can do both of that. So they will do the intensive intervention, which is multiple calls or interactions if it's through the web that last longer than 10 minutes with a goal of more than 40 minutes total. And so the evidence-based treatment for the general public would be for medications and counseling. So again, I'll talk about medications with pregnancy. And the counseling is really around the triggers, which are typically behaviors associated with smoking, and emotional triggers and social influences, family and friends. So I'm already looking at the clock. I might go a couple minutes over. So I wanted to let you know that we're not a hotline. We're not there to kind of talk somebody out of lighting up 24/7, but we're a program that somebody would enroll in. And we have 2 phone programs. Our sort of standard 4 programs is 4 outgoing calls and 8 weeks of combination over-the-counter nicotine replacement. So that's patch, gum, or lozenge. Then we also have a behavioral health program. So if somebody has a mental health issues or substance use issues that they think will make quitting tobacco more difficult, they can enroll in this program, and it's 7 outgoing calls in 12 weeks of the combination nicotine replacement. And again, if people don't want to talk to us, they can do an online thing. It's either it's called individual services or web coaching, and they can get 2 weeks of that starter kit for the nicotine replacement, and then they can opt into the phone program if they want to. So the staff that work there are nationally certified in tobacco treatment and have ongoing specific continued training. So these are the first line tobacco treatment medications: patch gum lozenge, inhaler, and nasal spray. Those all have nicotine. And then the 2 non-nicotine are pills, bupropion, which is also known as Wellbutrin or Zyban. It's all the same med, and varenicline, which is also known as Chantix. And these are the counseling strategies that we would use on the main quit link. So motivational interviewing, things like ORs, open-ended questions, affirmations, reflections, and summary. So we'll weave those into our conversations with folks. Asking permission before sharing information is just a really easy and powerful thing to do. It just decreases people's defenses. I can't think of any time when I've done that and somebody has said no, but it allows them to feel like they have a choice in what you're saying. And then cognitive behavioral therapy. So being really aware of unhelpful thoughts, helping folks with mindfulness and problem solving and coping strategies. So we do all, if you think of that triangle, if we're using medications and then the counseling strategies around the behaviors and emotions. And these are the 3 over the counter that we can offer: patch gum and lozenge, and we do it in combination. So pregnancy is one of those situations where it's not clear if medications are a good idea. We know that nicotine is a neurotoxin with teratogenic effects in the fetus, and that applies to nicotine replacement as well. But what we know is that if they're probably going to get less nicotine from the medications than they would if they were smoking. So or vaping, or using smokeless tobacco. So we first recommend behavioral changes, but what we have found is women who are pregnant who continue to smoke often have high levels of nicotine addiction. So it's okay to kind of think about medications. If we're using nicotine replacement, you usually use the lowest dose that you can mitigate withdrawal with. So maybe the short acting like the gum or the lozenge versus putting on the patch that's going to release continue nicotine. And then the varenicline and bupropion. So according to our medical director, varenicline and bupropion are category C, and the nicotine replacement are category D. So it's a decision the provider has with the patient. It's not that it's without risk, but again, it's typically less risky than continued smoking. And what I want you to know is that we wouldn't dose your patient without your approval. So if a pregnant woman enrolled with us and wanted to use medications, you would get a form from us. We would fax it to you, and it would say, they're looking to, we want to provide them with nicotine replacement. Are you okay with that? And we wait for that approval, and we wouldn't give it unless we had your approval. And on the bottom there's a few links that you can look up more about the medications that you might be interested in prescribing. And I had talked to Elaine, so I wanted to just do a couple more slides on products and nicotine levels. So just to remember, there's so many products out there now. There's, cigarettes and cigars and pipes and hookah on the bottom left, hookah, roll your own, vaping, smokeless. Those are some of the juices up here in the top right. And when I was putting this together, I was hearing about gummies too, and they come 12 to a packet, and they're a cigarette worth of nicotine per gummy. So, somebody can just eat these right down. And we're, of course, really concerned about adolescent brain and also for pregnant women and the impact on the developing fetus. So this is ongoing all the time. I'm trying to stay updated on these products. But just briefly, a cigarette, we think of a cigarette as about a milligram of nicotine when we're dosing somebody. It depends on the cigarette and how somebody smokes. It could be up to 1.8 milligrams of nicotine, but for dosing, we usually think of a milligram, and a pack would be 20 milligrams. So you can just see here, small cigar, there's huge discrepancy out there about levels, but this is just an average. Small cigar would be 3 milligrams, large 20 milligrams. So that's like a pack of cigarettes. The smokeless, you can see maybe a dose every time they put a wad of that in their mouth, how much they're getting. Hookah, somebody can smoke a hookah session with friends. Um, you know, in a 30 or 40-minute session, they might get anywhere from a pack and a half to 4 packs worth of cigarettes in a setting. And then vaping is a lot. So when it says 5% on the vape, people think that's really low because it's 5 out of 100, but it actually means it's 50 milligrams of nicotine in that. So it can be 1 to 2 packs of cigarettes per vape. And if you're confused by this, it's intentional, I believe, by the tobacco companies. It's confusing. We historically have underdosed people. Um, and so when I dose somebody, I just let them know what if you don't get enough nicotine from the product, you're going to have withdrawal, which is irritability, frustration, agitation, thinking about smoking. If you get more than what you're used to, you're going to have a little bit of toxicity. That's going to be lightheaded, dizzy, rapid heart rate. And so we tell folks this and then let them play around a little bit with the product, and we check in pretty soon afterwards. And just a quick slide that vaping is not vapor, it's aerosol, and it has all of this stuff in it. And we just don't know the long-term effect on the person that's smoking it or for the pregnant woman. So approximately 50 to 60 of women who quit during pregnancy will return to smoking, but if they receive treatment for that quit, they have reduced relapse. So to just continue to check in with them and focus on some of these strategies with them. And I thank you for going over for a couple of minutes. This is my contact information. I'd love to hear if we open up to discussion. If there's anything that you heard that you thought was particularly helpful, you might be able to use right away. I'm also interested in feedback. So after the fact, if you want to give me some feedback on this, this is my first and only echo I've ever done. So, you know, if I get asked to come back again, or if there's any way that I could help improve it, I'm interested. So thank you so much.